At 3 a.m. in the ICU, there's no time to translate in your head. A patient is crashing, monitors are screaming, doctors are shouting orders, and you know exactly what to do. But the English won't come out fast enough. If you're an international doctor or nurse who's ever felt brilliant in medicine but invisible in conversation, this episode is for you. Today on Learn English Lab, you will learn the real English used in emergency rooms, hospital wards, and high-pressure medical situations. The phrases, confidence, and communication skills that can save careers, build respect, and maybe even save lives. Because your English should be just as powerful as your clinical skills.
Yeah, and that's undoubtedly our mission today. We are stepping far, far beyond, basic anatomy textbook terms.
Right. If you're listening to this deep dive, you already know your medicine.
Absolutely. You are a highly trained professional. So our goal today is to really unpack the frameworks of trust, expand that critical vocabulary arsenal, and deconstruct real-life, high-stakes medical dialogues.
And we really need to reveal the unwritten cultural rules of Western hospitals, too.
Oh, without a doubt. We want to bridge that gap between your clinical expertise and your actual English fluency on the floor.
Okay, so let's unpack this right away because it is just so incredibly vital. Before a clinician can, deploy complex medical vocabulary or run a code, they have to first establish trust.
Right.
You only get one chance to make a first impression. And in a Western hospital setting, that first impression isn't just about being polite or, having good manners. It is an actual, measurable clinical tool.
It absolutely is a tool.
Yeah.
Building rapport-like, creating a close, harmonious relationship with a patient is a clinical necessity.
Yeah.
From a purely physiological standpoint,
Yeah.
if the patient does not trust you, their anxiety just spikes.
And we know what that does.
Right. It elevates their heart rate, increases their blood pressure, and dramatically drops their willingness to share a crucial medical history.
Yeah.
The language you use in those first 30 seconds strictly dictates the entire trajectory of their treatment.
Wow. So how do we engineer that trust rapidly, especially when you are speaking in your second or maybe third language?
Well, Western medicine actually has a framework for this.
A specific framework?
Yeah, we do. Let me introduce you to a highly effective standard framework used in a vast majority of American hospitals. It's called the 8-8-IT framework. That's AIDET.
Here's where it gets really interesting because it takes something as abstract as human connection and breaks it down into a reproducible linguistic checklist.
Spot on. It takes the guesswork completely out of patient interactions. So let's walk through the acronym. The A stands for acknowledge.
Okay.
You greet the person by name. You make eye contact, which is crucial in Western culture as a sign of honesty and attention. And you offer a warm smile.
So you're acknowledging their humanity first before addressing the illness.
Accurate.
Right? They aren't just, the gallbladder in room 4. They are Mr. Chen. And the phrasing here matters, doesn't it? It's not just a casual, hey.
No, definitely not. Good morning, Mr. Chen. Then comes I for introduce. You state your name, your specific role, and your purpose for being in their room.
It's a clarity.
Yes. In English, clarity here is paramount. I am the respiratory therapist, or I am one of the nurses on your team today.
Got it. Then D for duration, giving a clear time expectation. I imagine this is so important for patient psychology.
Oh, it really is. You use phrases like, this should take about 10 minutes, or I'll be back in an hour to check your pain.
Followed closely by E for explanation.
Right. This is a step-by-step walkthrough of the procedure using patient-friendly language. You want to avoid dense medical jargon here.
And finally, T.
T for thank you. Expressing gratitude for their cooperation and, their patience. Thank you for letting me do this. Or I appreciate your patience while we waited for these lab results.
Let's see this in action to highlight the language difference. Let's look at the wrong way to do this first.
Okay, let's do it.
Imagine you are going into a patient's room to place an IV. The wrong way would be walking in and simply saying, hi, I need to start your IV.
Yeah, the English is grammatically correct there, but the impact is terrible. It is abrupt, startling, and it completely ignores the patient's agency.
It sounds like a demand.
It really does. Now let's contrast that with the ADA phrasing. You walk in, you acknowledge, good morning, Mr. Chen. My name is David.
Making that eye contact.
Right. Then introduce. I'm one of the nurses on the team today, and I'm here to place your IV line.
Then duration. The whole process should only take about 5 minutes.
Notice how that duration instantly lowers anxiety. The patient isn't left wondering if they're going to be, poked and prodded for an hour.
Then the explanation. I'll be placing a small plastic tube, called a catheter, into one of the veins in your arm. This will let us give you the fluids and medication the doctor ordered. You'll feel a quick pinch, but it shouldn't be too painful. I'll be here the whole time.
Perfect. And finally, the thank you. Thank you for your patience as we get this started. Are you ready?
The difference is just staggering.
It is. The second version is infinitely more professional and builds a massive reservoir of trust. The patient feels seen.
I actually have an analogy for this. ADET is kind of like a pilot's pre-flight announcement.
Oh, I like that. How so?
Think about it. The pilot comes on the intercom to say, "We'll be flying at 30,000 feet. We might hit a little turbulence over the Rockies, but we'll be in Chicago in 2 hours."
Right.
That announcement doesn't change the mechanics of the airplane. It doesn't make the engines work differently, but it completely neutralizes the passenger's fear of the unknown.
That is a wonderful comparison, really spot on. And if we connect this to the bigger picture of clinical outcomes, those duration and explanation steps specifically shift the patient's mindset.
They transition from feeling like a passive victim.
Exactly, to whom things are being done, into an active, empowered partner in their own care.
Because they know the flight path.
Indeed they do.
Yeah.
But, once the patient trusts you, you face the next major communication hurdle. You have to be able to give them instructions that keep them safe long after they leave the hospital.
Which brings us to a massive pain point in Western healthcare. One of the absolute highest risks for miscommunication and subsequent hospital readmission is failed patient education.
It is a systemic issue, undoubtedly. When a patient goes home without fully comprehending how to take their medicine or how to care for a surgical wound, they very often end up right back in the emergency room.
And if there is a language barrier on top of all the medical jargon,
the risk just skyrockets.
So how do we ensure comprehension? Because simply asking, "Do you understand?" doesn't really work, right?
No, not at all. Patients will almost always nod and say yes, just to avoid looking foolish. Strictly speaking, do you understand is probably the most dangerous question in medicine.
Wow. So what do we do instead?
The most robust method to verify comprehension is called the tell, show, do method, immediately followed by a teach back.
Tell, show, do, and teach back. Let's break down the English phrasing for these 4 steps.
Sure. Step 1 is tell. You explain the instructions as simply and clearly as possible using active verbs. Step 2 is show. You physically demonstrate the task using a medical model, maybe a placebo device, or even your own body.
Step 3 is do.
Right. The patient performs the task while you observe them. And step 4, the absolute linchpin of the process, is the teach back. You ask the patient to explain the instructions back to you in their own words.
Let's run through a practical example from our deep dive. We have an interaction with a Mrs. Gupta who is being prescribed a rescue inhaler.
Okay, for the tell portion, the nurse needs to use short, digestible sentences like, "This is a rescue inhaler. You'll use it when you feel short of breath."
Short and clear.
Right. The first step is to shake it well for about 5 seconds. Then you'll breathe out all the way, put the mouthpiece in your mouth, and as you start to breathe in slowly and deeply, press down on the canister 1 time. Hold your breath for 10 seconds, and then breathe out slowly.
That is a lot of sequential information. And words like canister and mouthpiece might be totally new to the patient.
Which is exactly why the clinician moves straight to show. Using a practice inhaler, you physically model the timing.
You shake it, pretend to breathe out, put it to your lips.
Press while breathing in, and visibly count out the 10-second hold on your fingers.
Which leads seamlessly into do. The nurse hands the practice inhaler to Mrs. Gupta and uses an inviting phrase, right? Like, "Now it's your turn. Can you show me how you would use it?"
Yeah. And then the nurse observes and provides gentle, real-time corrections. And then comes the crucial teach back.
So what's the phrasing for that?
The nurse says, "That was excellent. Just to be sure we're on the same page, can you tell me in your own words when and how you're going to use this inhaler?"
And Mrs. Gupta replies, "I'll use it when my breathing gets tight. I'll shake it, breathe out, and then as I breathe in, I press it and hold my breath for 10 seconds.
See? The loop is successfully closed. You have verified actual comprehension, not just polite nodding.
I do have to ask, though, and maybe push back a little here on the cultural side.
Here, go ahead.
If I'm an international clinician, is there a risk that asking a grown adult patient to teach it back to me sounds, well, condescending? Like a kindergarten teacher talking to a child. It feels a bit unnatural.
Oh, that is a very common fear, and it is a completely valid cultural concern.
Yeah.
In many cultures, challenging an elder or an adult in that way is considered, highly disrespectful.
Yeah, exactly.
But this raises an important point about how we frame the English. The teachback is never a test of the patient's memory or intelligence.
What is it then?
It is strictly a test of the clinician's teaching ability.
Oh, that's a massive mindset shift. So it's about taking the blame.
Without a doubt.
Yeah.
You frame it by taking the burden completely upon yourself. The phrases you use are critical here.
Like what?
You say something like, I want to make sure I did a good job explaining this, or medical instructions can be confusing and I want to be sure I didn't leave anything out.
Mm-hmm.
Could you explain to me how you'll take this at home?
You are literally asking them to grade your teaching.
Spot on. If the patient gets it wrong, the clinician must take the blame and say, I'm sorry, I didn't explain that clearly enough. Let me try again.
That framing completely removes the condescension. It's brilliant.
It really works.
Now, to execute a perfect teachback, or a flawless ADA explanation, a clinician needs the right English words at their immediate disposal.
They certainly do.
So, it's time to build the vocabulary word bank. We are going to go through an expansive list of over 40 essential medical terms.
And what's vital here is that we aren't going to insult your intelligence by teaching you the underlying biology. You already know what these conditions are.
Right. This is about the language.
Strictly the language.
Yeah.
We are focusing purely on pronunciation, preposition pairings, abbreviations, and the high-stakes clinical context where these English words live.
To make this practical, let's group these terms by following the narrative of a patient's journey through a hospital shift.
I love that approach. Let's start at the very beginning of a clinician's day, arriving at the hospital and taking over the shift.
Which brings us to our first set of terms related to general hospital operations. The first word is handoff, pronounced hand-off.
Right, handoff. This is the transfer of patient care. In English, we usually use this as a noun like, I need to give handoff, or we are in the middle of handoff.
This is perhaps the most vulnerable moment in a patient's care, isn't it?
Undoubtedly. All the critical information gathered over the last 12 hours must be accurately transmitted.
And right after handoff, you usually have rounds. Pronounced rounds.
Yes. This is when the medical team goes from room to room to discuss patients. And the key preposition here is making.
Making rounds.
Correct. You don't do rounds, you make rounds. The attending physician is making rounds now.
And rounds in a Western hospital are highly collaborative, right?
Very much so. You often have the senior doctor, residents, medical students, the bedside nurse, and sometimes the pharmacist all standing outside the patient's room, debating the diagnosis and finalizing the treatment plan.
So you have to be ready to speak up and present your patient clearly in English.
Spot on. Now, sometimes the doctor on rounds isn't in the hospital all the time. They might be on call.
Hyphenated, pronounced on call.
Yeah. This means they are available to be paged, usually after hours. I'm the on-call surgeon tonight. It means they might be sleeping at home, but if a trauma rolls in at 2 a.m., they must arrive rapidly.
During handoff and rounds, there is a word that dictates everything you can and cannot say. IPAA, spelled H-I-P-A, pronounced H-I-P-A.
OIPA. This is the Health Insurance Portability and Accountability Act. It is a fiercely guarded pillar of American healthcare protecting patient privacy.
How is it used in a sentence?
In spoken English, it's almost always used as an adjective modifying a violation. Like that's a high PI violation.
Meaning you cannot share identifying information about a patient with anyone not directly involved in their care.
Right. A casual conversation in an elevator overheard by a stranger can result in massive fines.
And violating those standards brings us to malpractice. Pronounced malpractice.
Yes. Malpractice isn't just making an honest mistake. It's a specific legal term for a deviation from the accepted standard of care resulting in harm.
So you might hear failing to verify patient identity before giving medication is a major malpractice risk.
Accurately stated.
Okay, so you've received your handoff, you understand the legal boundaries, and now you're evaluating a newly admitted patient. Let's look at the vocabulary for patient conditions.
Great. Let's say you walk into the room and the patient is lethargic. Pronounced lethargic.
The stress is on the second syllable, lethargic.
Right. Now, in casual, everyday English, someone might say, I'm feeling lethargic, just meaning they are a bit tired.
Yeah.
But in a clinical context, lethargic implies a significantly altered state of consciousness. A lethargic patient might drift off to sleep in the middle of answering your question. It's a severe clinical sign.
Got it. Then the family tells you the patient had an episode of syncope, pronounced S-I-N-cope, 3 syllables. The E at the end is not silent.
Right, syncope.
This is the medical term for fainting. He had an episode of syncope while standing up.
Do clinicians use that word a lot?
Actually, you will often hear clinicians use the adjective form syncopal episode instead of the noun alone. And when explaining this to a patient's family, you wouldn't use syncope. You would just say he passed out or he fainted.
Right, keep it simple. Next, you look at the patient and you notice they are jaundiced, pronounced jaundiced.
The noun is jaundice, jaundis. We know this is the yellowing of the skin and eyes from high bilirubin.
And in English, we often use it as an adjective. The patient appears jaundiced.
Spot on. Then let's say you run an EKG because they are complaining of chest pain, and you see signs of ischemia. Pronounced is chemi-u. The chi makes a hard K sound.
Ischemia, inadequate blood supply.
Right. The EKG shows signs of cardiac ischemia. Ischemia is the precursor to tissue death. The adjective is ischemic, as in ischemic tissue.
Let's assume the patient is critically ill, so we need to start interventions. This brings us to the vocabulary for procedures and equipment.
Let's do it.
First, we need a central line, pronounced a central line.
Notice the phrasing clinicians use here. We don't say we put a central line. We say the doctor is going to place a central line or insert a central line.
Place or insert?
Yeah. This is the large IV catheter placed in a major vein in the neck, chest, or groin for delivering highly concentrated medications.
To monitor their fluid balance accurately, you might need to insert a Foley catheter, pronounced Foley catheter.
Though on the floor, nurses rarely say the full name. They just call it a Foley, as in, I need to place a Foley, or let's check the Foley output.
What if the patient's abdomen is terribly distended? You might need to place an NG tube. That stands for nasogastric tube, pronounced NG tube.
Again, we rely heavily on abbreviations. We rarely say nasogastric. We say we're placing an NG tube to decompress the stomach.
Decompressing.
Yeah, decompressing is the verb we use for hooking it up to the wall suction to pump the stomach out.
Since this patient has suspected cardiac issues, you'd order an EKG or ECG, pronounced EKG, electrocardiogram.
Interestingly, in the U.S., EKG is much more common in spoken English than ECG, even though both are technically correct. You'll hear, let's get a 12-lead EKG, stat.
Stat. We'll get to that one in a minute. Let's talk about some more invasive procedures they might need later. Perhaps a paracentesis, pronounced parucentesis. 5 syllables, stress on the T.
This is removing excess fluid from the abdomen, usually due to liver failure. The verb pairing is usually perform. The attending will perform a paracentesis.
Or they might need an endoscopy, pronounced endoscopy. Stress on the DOS.
The camera into the digestive tract, patients will often just call this having a scope down my throat.
If they suspect meningitis, they'd order a lumbar puncture, pronounced LUM bar puncture.
In medical charting, it's an LP. But when speaking to a patient, you almost never use the term lumbar puncture.
What do you say?
You say spinal tap. Like, we need to do a spinal tap to check the fluid around your spine.
Let's imagine our patient had surgery recently, and we are checking their surgical site. We might see dehiscence. This is a tricky one to spell and say. Pronounced dehiscence. It means the splitting open of a surgical wound.
It is a terrifying complication. You would report this by saying, the patient's abdominal wound is showing signs of dehiscence.
And if the wound has dead tissue, it will require debridement, pronounced debridement.
The removal of dead or infected tissue, the verb is debride. The surgeon needs to debride the wound.
And to help that wound heal, we might apply a wound vac, pronounced wound vac.
This stands for a vacuum-assisted closure. It uses negative pressure. You would say the wound vac needs to be changed every 48 hours.
What if our patient has a collapsed lung? They would need a chest tube.
Right, a drainage tube inserted into the chest to remove air or fluid. The common phrasing is, we need to insert a chest tube, and when it's time to take it out, we say, we are going to pull the chest tube.
Pull, not remove.
Yeah, we don't usually say remove, we say pull.
Okay, we have our lines and tubes in place. Now it's time for pharmacology and medication administration. This is where English usage gets very specific.
It definitely does.
The first term is bolus, pronounced BOH-less.
This is a single large dose of a drug or fluid, usually given intravenously. It implies urgency. The patient's blood pressure is crashing. Give a 500 cc fluid bolus now.
You can also use it as a verb, right?
Yes. I'm going to bolus 500 of saline.
What if the patient is on a powerful medication that needs to be constantly adjusted? We use the word titrate, pronounced titrate.
right, to adjust the dose to achieve a desired effect. The grammar here usually involves the preposition to. Titrate the dopamine drip to maintain a mean arterial pressure above 65.
So it means you are constantly dialing the medication up or down, drop by drop.
Spot on.
If we need to get a medication level high very quickly, we give a loading dose, pronounced LOH ding dose.
An initial higher dose commonly used with antibiotics. Start with a 1 gram loading dose of vancomycin, followed by a maintenance dose.
And what if they are on a medication that their body is physically dependent on, like strong steroids? We have to taper it, pronounced taper.
To gradually reduce the dosage, we need to taper the steroids slowly to avoid withdrawal. You don't stop it, you taper it off.
For pain management, a doctor might write an order for a medication to be given PRN, pronounced PR.
It stands for the Latin pro re nata, meaning as needed. This is deeply embedded in English medical slang. You will hear nurses say, "Did you give the PRN?" or "She's asking for her PRN pain meds."
Meaning the nurse uses clinical judgment to give the drug if the patient needs it.
Exactly.
Some medications need to bypass the digestive system entirely, so they are given sublingual, pronounced sublingual.
Under the tongue. Give the nitroglycerin tablet sublingually. When explaining this to a patient, you say, "Let this dissolve under your tongue. Do not swallow it."
Let's talk about drug classifications. A patient with dangerously low blood pressure needs a vasopressor, pronounced vasopressor.
A medication that constricts blood vessels to raise blood pressure. In casual floor slang, these are often just called pressors. He's hypotensive. We need to start him on pressors.
An anxious patient might need a sedative, pronounced sedative.
A drug that calms the central nervous system. We'll give a mild sedative before the procedure.
A patient at risk for blood clots will be put on an anticoagulant, pronounced anticoagulant.
Right. He's on warfarin, an anticoagulant. But here is the critical language tip. You rarely use the word anticoagulant with a patient. It's too complex.
So you'd say,
You call it a blood thinner. So you take your blood thinner every day.
and a patient with fluid overload needs a diuretic, pronounced diuretic.
A drug that increases urine production to remove excess fluid. Again, translating to patient English, we call this a water pill. This water pill will help bring down the swelling in your legs.
Speaking of swelling, let's look at a few more patient conditions that arise during our shift. That swelling is called edema, pronounced A-D-E-E.
Fluid trapped in the body's tissues. You will hear the phrase pitting edema, meaning if you press your thumb into the swollen tissue, it leaves an indentation.
He has 3+ pitting edema in his lower extremities.
Yep.
Our patient might develop an irregular heartbeat, specifically AFib, which stands for atrial fibrillation.
In spoken English on the floor, nobody says atrial fibrillation. It takes too long. Everyone says AFib. His heart just went into AFib with a rapid rate.
What if a patient with a stroke risk has trouble swallowing and food goes into their lungs? That is aspiration, pronounced as P-A-R-A-shun.
Breathing a foreign object or liquid into the airway.
Yeah.
Elevate the head of the bed to reduce the risk of aspiration. We also use it as a verb. He aspirated his lunch.
The most terrifying complication is an embolism, pronounced embolism.
A blockage in an artery, usually a blood clot. A pulmonary embolism is often abbreviated as a PE. We suspect a PE, get a CT scan.
Which brings us to the most urgent terminology. If our patient's heart stops, you will hear the phrase code blue, pronounced code blue.
The universal hospital code for a cardiac or respiratory arrest. Code blue, room 502.
During a code or any emergency, a doctor will yell for things stat, pronounced stat.
Some of the Latin statum, meaning immediately. I need a portable chest x-ray, stat. It bypasses all scheduled orders.
But wait, before we start chest compressions, we have to know the patient's legal status. Are they a full code, pronounced full code?
By default, every patient is a full code, meaning we perform all resuscitation measures.
Or are they a DNR, pronounced DNR, do not resuscitate?
This is a legally binding order indicating they do not want CPR or electric shocks. Check the chart to confirm the patient's DNR status.
This status is often dictated by a living will, pronounced living will.
A legal document specifying medical wishes if they cannot communicate. Her living will outlines her desire to avoid a ventilator.
And finally, for patients nearing the end of their journey or dealing with a severe chronic illness, we consult palliative care, pronounced palliative care.
Specialized medical care focused on providing relief from symptoms and stress. A crucial distinction in English. Palliative care is not the same as hospice.
Right.
Hospice is strictly for end of life. Palliative care can happen at any stage to improve quality of life.
Okay, that was a monumental list. But those 40 terms by themselves are really just tools sitting on a table. It's time to see how they are actually wielded in the high-stress, deeply human reality of the hospital floor.
Yes. Let's move into deconstructing some real-life medical dialogues. These are not textbook two-line exchanges. They contain subtext, emotion, and profound professionalism.
It's about how English is used to navigate human emotion.
Accurately stated.
We have 2 dialogues to analyze. Let's start with Dialogue 1, which takes place in the pediatric unit. The setting is the pediatric floor. Nurse Sarah is speaking to Mrs. Davis, the highly anxious mother of 6-year-old Leo, who is running a 103-degree fever.
The first thing to notice here is the dual layer of this conversation. Nurse Sarah isn't just treating Leo's physical fever, she is actively treating the mother's acute anxiety.
Which is standard practice, right?
Yes, in Western medicine, treating the family's anxiety is absolutely considered part of the clinical job.
I noticed the language Sarah uses. The mother says she is terrified because the ER doctors thought it was just a virus, but they weren't sure, and she asks, what if it's something serious like meningitis?
And how does the nurse respond?
She doesn't dismiss her fear. She doesn't just say, don't worry. She validates it. She says, that's a very valid concern, before reassuring her that the pediatrician is reviewing everything.
Validation is a powerful de-escalation tool in spoken English. By saying, that is a valid concern, the nurse aligns herself with the mother. They're on the same team.
Whereas if she just brushed it off.
If you simply say, everything is fine, an anxious native speaker will feel patronized and ignored.
And then there's this wonderful practical moment. The mother says Leo absolutely refuses to drink water, and Nurse Sarah brings out what she calls the rocket ship popsicle, tricking him into hydrating by making it fun.
Oh, I love that.
She says to the child, do you think you could take a few sips as this rocket ship melts?
It's a classic pediatric technique, bypassing the battle of wills over a cup of water. But the linguistic part that really stands out happens next.
Yes. The nurse turns back to the mother and asks if she has eaten anything today. The mother is surprised and says she hasn't even thought about food since yesterday.
Right.
And Nurse Sarah uses this amazing English idiom, you can't pour from an empty cup.
That empty cup idiom is a masterclass in empathetic communication. Let's break down why this works so well in English.
Please do.
The nurse recognizes that telling an anxious mother you need to eat for your own health will fail, because the mother feels guilty thinking about herself.
She's focused entirely on Leo.
Right. So the nurse frames the mother's self-care as a clinical necessity for the child. She essentially says, Leo needs you to be strong. And that means you need fuel. You cannot give him energy if you have no energy yourself. You can't pour from an empty cup.
Wow.
She convinces the mother to eat a sandwich by making it an act of caring for Leo.
That is beautiful. It's an idiom that international clinicians should absolutely add to their vocabulary.
Totally.
Now, let's contrast that deeply emotional, metaphorical exchange with Dialogue 2, the data-dense shift handoff.
Right, a completely different environment. The setting here is the nurse's station at 7:00 p.m. Day nurse Maria is transferring care to night nurse Kevin.
The stark contrast in pace and tone from the pediatric dialogue is wild. This is rapid-fire, highly structured communication packed with acronyms.
Yeah, Maria moves seamlessly through the patient's history.
Listen to this density. Jane Doe, room 204, full code, admitted with community-acquired pneumonia, history of COPD, and type 2 diabetes.
Every single word carries massive clinical weight. In 2 sentences, Kevin knows the patient's baseline, her primary acute problem, her chronic comorbidities, and her resuscitation status.
It's incredibly efficient.
International clinicians must practice this specific cadence. It cannot be slow or hesitant.
Maria then dives into the current vitals and medications. She mentions that Jane had a blood sugar spike of 280 before lunch. They gave her 6 units of sliding scale insulin, and it came down to 190. And she notes that the patient has PRN Tylenol for chest pain.
Let's look at the phrase sliding scale insulin. This is standard floor jargon.
Right.
Maria isn't just giving static numbers. She's describing a clinical trajectory. She is explaining how the patient's body responded to interventions during her shift, which tells Kevin specifically what to anticipate on his shift. He knows he has to watch those blood sugars carefully.
But the hallmark of an exceptional handoff, the part that separates an average clinician from a great one, is the very final detail Maria provides.
What does she say?
After all the complex data, she says, oh, and one more thing. Jane is a bit hard of hearing in her left ear, so make sure you speak up and face her when you talk.
That is the human element shining through the clinical data.
It's such a small thing, but so important.
That seemingly small, non-medical detail prevents Kevin from walking in, speaking to her left side, getting no response, and immediately calling a code stroke because he thinks she is unresponsive. It prevents a catastrophic communication breakdown right at the start of his shift.
These interactions, whether it's using idioms with a worried mother or firing off acronyms to a colleague, don't happen in a vacuum. They happen within a very specific cultural framework that international workers must learn to navigate.
That brings us to our final section, cultural communication tips and the unwritten rules of the Western hospital landscape.
Because the medicine might be universal, but the workplace culture absolutely is not.
No, it's highly specific.
First up on navigating the social and hierarchical landscape is something that can really catch international staff off guard. Gallows humor. Dark humor.
Oh, yes. Dark, morbid humor is highly prevalent in Western hospitals, particularly among nurses, residents, and emergency staff operating in high-stress units.
I can imagine.
It can be incredibly shocking if you originate from a culture where discussing death or illness is strictly solemn, formal, and reverent.
I can easily see a new international nurse hearing a joke about a cardiac arrest and thinking these people are monsters.
Exactly. But the deep dive clarifies that this humor is not a sign of disrespect for the patient. It is actually a vital psychological coping mechanism.
It's how they deal with it.
Right. It's how staff bleed off the intense daily stress and trauma they witness. When the team jokes after a horrific trauma code, they are not laughing at the tragedy. They are using humor as a pressure release valve to survive the shift so they can go treat the next patient.
So you don't have to join in if you don't want to.
No, you are certainly not required to participate in it or make those jokes yourself. But understanding why it happens prevents you from feeling alienated or judging your colleagues as callous. It is a shared survival tactic.
Our next unwritten rule is a huge one. It's what we call the art of disagreeing up. How do you challenge a senior doctor or a charge nurse if you think they're making a mistake without getting fired or seeming insubordinate?
Because in many cultures, questioning a superior is strictly forbidden.
Exactly.
It is a delicate art in English. The fundamental rule is never flatly say, "You're wrong," or "That is a mistake,"
Even if they are wrong.
even if they are. In a high-stress, hierarchical setting, a direct challenge triggers instant defensiveness. Instead, you use clarifying and questioning phrases to guide them to the right answer.
It's like verbal judo. You are using the momentum of your own curiosity to safely challenge their authority.
Yes.
For example, instead of saying you ordered the wrong dose, you might say, "Dr. Smith, can you help me understand the thinking behind that order? I'm just trying to learn."
Or if you suspect a dangerous medication error, you frame it as your own potential misunderstanding. You say, "I just want to double check. My understanding was that the patient had an allergy to that class of drug. Did I misread the chart?"
Or maybe, "I'm a little concerned about their blood pressure trending down. Would you be open to reevaluating the dosage?"
Those are perfect. You are showing total respect for their authority while fiercely advocating for your patient's safety. By phrasing it as a question or a request for clarification, it gives the senior clinician an elegant way to realize their mistake, check the chart, and correct the order without losing face in front of the medical team.
Let's look at another cultural quirk that confuses so many people. The multifaceted sorry. This is wild.
Oh, this is a big one.
In American, British, and particularly Canadian cultures, the word sorry rarely means I accept legal blame for this error.
Yeah, that is a major fear for international doctors. They are taught never to say sorry because it admits malpractice guilt.
But in English, sorry serves as a universal social lubricant. It frequently just means, excuse me, as in, sorry, can I just get past you to grab this IV pole?
Or it operates as a profound show of empathy. A doctor will sit with a family and say, "I'm so sorry you're going through this."
Meaning, you didn't cause their cancer, but you are expressing deep human sorrow that they have to endure it.
Spot on. International workers shouldn't be afraid to use the word thinking it automatically implies liability. It actually builds immense trust.
And our final cultural tip revolves around first names versus titles. The culture in modern Western hospitals is shifting rapidly toward first names, which can feel, uncomfortably casual.
But there is a golden rule here to keep you safe. You address physicians as Dr. Last Name until they explicitly invite you to use their first name. You don't just assume you can call the chief of surgery John.
That makes sense.
However, among nurses, respiratory therapists, and allied health staff, first names are almost exclusively the standard.
Using overly formal titles with your nursing peers, like calling your charge nurse madam or sir, might actually create an artificial barrier to teamwork.
Really?
Yeah, it can make you seem aloof or rigid. Learning to comfortably use first names with your peers is a huge step in cultural integration.
We have covered incredible ground today. From the 8 framework and the teach-back method to rapid-fire pharmacology pronunciation, from pediatric idioms to the nuances of gallows humor and disagreeing up.
It's a lot to process.
It is, but I want to land the plane on a philosophical note that ties all of this language learning together.
Okay, let's hear it. It centers on the concept of vocation, doesn't it?
It does. The etymology of the English word vocation comes from the Latin word vocare, which means to call.
Right. Working in healthcare isn't just a job you clock in and out of to get a paycheck. It is a calling. You are called to heal, to comfort, and to serve people on the absolute worst, most terrifying days of their lives.
And if you are listening to this and you move to a new country, or if you decided to practice medicine in a second language, you answered a second calling, a much, much harder calling.
It means you are fighting a daily battle on 2 fronts simultaneously. Every single shift, you are fighting the physical battle against disease, and you are fighting the internal, exhausting mental battle against the language barrier.
And the rallying cry is this: every single patient you successfully treat, every new English phrase you learn and deploy on the floor, every teach-back you successfully execute means you are winning.
The Western hospital system desperately needs your unique perspective, your culture, and yes, your accent. It creates a diverse, life-saving symphony of care. Do not let the fear of a misplaced preposition or a mispronounced syllable silence your clinical brilliance. You are a confident clinician, not an imposter.
This raises an important, provocative question I'd like to leave you with, something to mull over on your next drive to the hospital.
What if your language barrier is actually a hidden superpower?
A superpower? How could struggling with English be a superpower?
Think about it. Because you have to think so deliberately about the words you choose, you are inherently protected from going on autopilot. Native speakers often rattle off medical instructions mindlessly looking at their clipboards because the words come entirely too easily to them.
That makes total sense.
But you have to be deeply intentional. You have to be highly present, watching their face, and hyper-focused on your patient's actual comprehension. That extra cognitive effort makes you a more attentive, deeply empathetic clinician than someone who takes their native tongue for granted.
Wow. What a perspective shift. I absolutely love that. The barrier makes you better.
Keep learning. Keep practicing the phrasing. Keep stepping into those patient rooms with your head held high, knowing the immense value you bring.
Because remember, at 3 a.m. in the ICU, when the monitors are screaming, your clinical brilliance is already there. Now, your words will be too. Keep answering your call.
Thank you for joining us on this deep dive. Like, share, and subscribe to this YouTube channel. Please, if you found value in this, ensure you support Learn English Lab so we can keep bringing you this level of analysis. We will see you next time.